everyone. Welcome. So glad that you could all be with us today. For some of you, it's early. For some of you, it's late, but thank you for carving out the time. It's so glad to have you here. We are the Academy of Biomimetic Dentistry, and you are joining us today for a live presentation from the one and only Dr. Junji Tagami. So we are in for a big treat today. I'm going to go over just a couple of things really quick before we get started. My name is Carla. I am the Executive Director for the Academy of Biomimetic Dentistry. I would like to introduce our board of directors. Dr. Mark Lazar is our president. Dr. Saul Pressner is our president-elect. Dr. Teresa Monson is vendor liaison. Dr. Joseph Sutton is our secretary. Dr. Michael Haney is our treasurer. Dr. Diane Caprio of scientific affairs. Dr. Paul O'Malley with membership. Dr. Jim Erpenbach is a board member. Dr. Melissa Siebert is a board member. Dr. Charles Rufinach, board member, and Dr. Jay Resnick, board member. Thank you to those board members that are with us today. So glad to have you. And a special welcome to all of our scientific advisors. I know I saw Dr. Matt Najad, Dr. Grant Ches. Hello, welcome. Thanks for joining us today. So glad to have you. We are going to be recording today's presentation, so you will have access to that after the presentation. You'll get that email link once it is ready for you to view. We do ask that today, if you could please make sure that your microphones are muted. That will help us not to have any interruptions during the presentation so we can all make sure and hear. With that in mind, during the presentation, if you have any questions, please feel free to put those in the chat. If you would, please start it with a Q so that we know that that's a question. And then after today's presentation, we will do a live question and answer with Dr. Junji Tagami, where we'll answer all of those questions. Today's presentation is sponsored by Curare Noratech Dental. And join us in 2 weeks, Saturday, April 24th at 5 p.m. Eastern. Dr. Junji Tagami will also be giving us a presentation that Saturday, 5 p.m. Eastern, New York time. Today, we will be offering CE for the lecture for those of you that have registered. If you have not registered for CE and you would like to get CE for today's presentation, please private message me in the chat bar and I will make sure to take care of that. We do need you to purchase your CE during the presentation today to be considered for CE. We do ask that if you are here for CE that you stay for the entire duration of the presentation from beginning to end. After the presentation, we will have a CE code that will ask you to copy and paste. You'll need that to claim your CE certificate. For our CE today, it is sponsored and brought to you by Dental Digest. Dr. Melissa Siebert handles that and takes care of that for us. If you have not already, make sure to go out and like Dental Digest on Instagram. Check out the podcast. Amazing information there for all of us. To get things started, we are going to begin with a polling question. That's going to be for our CE. So that's going to pop up on the screen. We're going to give you a chance to see what that looks like. If you could answer the polling question, Matt will be popping that up here.
Yep, I sure will. I'm just going to pop that up.
We'll also have a polling question right after the presentation. All right, that's up there. This is a tough one. Are you a current member of the Academy of Biomimetic Dentistry?
Don't lie, everybody. Yes.
Awesome. So it's not that hard, very easy. That's what a polling question's like. So we'll have another one just following the presentation. Don't forget to post your questions in the chat bar and private message me if you need CE, or if you're not sure if you've signed up, we can double check that for you. And without further ado, I would like to introduce the president of the Academy of Biomimetic Dentistry, Dr. Mark Lazar.
Thank you, Carla. I'll tell you, this is amazing. We have a great turnout today, very excited. Today, I have the distinct pleasure of introducing the great Dr. Junji Tagami. Dr. Tagami has recently retired as the professor of Cariology and Operative Dentistry at Tokyo Medical and Dental University in Japan, after 26 years in that position. He was the vice president and past dean of TMDU and is now the executive director for education and international student exchange. Now, Dr. Tagami is a renowned lecturer, but he has also published more than 450 peer-reviewed international dental journals, dental articles. His research on the mechanism and structure of caries is perhaps one of the most important contributions to the field of minimally invasive biomimetic dentistry. Additionally, his development of the optical coherent tomography for dental diagnosis and laboratory material testing is one of his most wonderful achievements. Now, I've had the privilege of getting to know Dr. Tagami when he was our keynote speaker a few years back, and he's a fascinating man with great family values and a true appreciation of nature. And Dr. Tagami has been a great friend and a mentor to us here at the Academy of Biomimetic Dentistry. And it's for this reason that we have awarded him an honorary fellowship in the ABD and invited him to become a member of our distinguished group of scientific advisors. So without further ado, I would like to turn this webinar over to Dr. Junji Tagami.
Ladies and gentlemen, thank you very much for everyone to have provided me this very great opportunity. As you may know already, I have just retired from the university at the end of March, and now I enjoy my favorite works. Of course, I like the dental clinic as well as dental research. I'm very lucky to be able to continue those activities even after my retirement. And this kind of program is very, very important and very happy for me. So in Japan, the cherry blossom finished about 2 weeks ago, but still at the top of the Mount Fuji, we have the snow. And gradually we have a very wonderful weather situation in springtime. And this morning, a golf ball came into my lecture room from Augusta, Georgia. This is my room. It's very nice to enjoy this kind of live TV program of Masters Tournament because I stayed about 1 year at Augusta, Georgia in the year of 1987 and 88. I did some kind of research about dentin permeability with Dr. David Pashley at Medical College of Georgia. So it was a long time ago. And now I'm talking from this part of my room. And in Japan, the sunrise is just before 6 a.m. and it's 6:10 a.m. And because of the huge building near to my house, the sunrise at my house is 6:20 or something like that. Always this time, the sunrise from the huge building of Sony and another kind of a huge electric company. Anyhow, it's nice to share the same sun at the middle of the Pacific Ocean with you. Today, I'll talk about this topic, removal of caries lesion without pain. Of course, the removal is done without the shot of Xylocaine. Okay, and the dental treatment without the shot is very, very well accepted by my patient. Of course, most patients doesn't like pain, but also the patient don't like to have the shot. So today I will talk about the treatment of caries. So in the past time, it was often said that once we have a small restoration, because of the recurrent caries or secondary caries, it becomes bigger and bigger. And finally, we need to apply the endo treatment. and sometimes the root is broken. Unfortunately, the patient lose their teeth. To stop this kind of very bad cycle, the so-called minimal intervention is recommended by the FDI, by the Committee of the Restorative Dentistry in the FDI. In this MID statement, there are 6 issues, and from 1 to 4, the importance of the prevention of caries and the remineralization of the early caries region is strongly recommended. And at the number 5, the so-called minimally invasive operative interventions to ensure tooth survival is recommended. To achieve this, we need to apply the minimally invasive caries removal, and also the adhesive resin material should be applied. And also after the restoration, the repair is recommended. Before we start to talk about the caries removal, the reasons for the tooth mortality should be reviewed. This is a result reported by Dr. Axelson, and he provided the very excellent maintenance program for his patient, about 257 patients for 30 years. During the 30 years, the total number of the tooth loss was 173 only, because if we calculate the average number of the tooth loss per person is less than 1. However, we should consider about the reason of this tooth loss. The most frequent root reason of the tooth loss was root fracture, 62%. And most of those cases, it had this kind of metal core building up. Because of this kind of restoration, a lot of patients suffered from the fracture of the root. This tendency is the same even now in Japan. And if we include the root resorption and the endo treatment, it will be about 80%. So I can say that 80% of the tooth loss was related to the endodontic problems. That's why the protection and saving the pulp tissue is very important to save the teeth of our patient. My teacher, Dr. Takao Fusayama, published this book, New Concept in Operative Dentistry. At the end of 1970s, he could develop the adhesive resin material as well as the minimally invasive caries excavation technique using the caries detecting dye solution. And this book was very well evaluated by the past president of FDI, Professor Louis Baum, and he mentioned that this is an innovation in operative dentistry. The paradigm shift from the mechanical approach was occurred to the biological approach. So this was based on his excellent research work on denting caries. So his philosophy was very well accepted, supported by Dr. Raymond Bartolotti, and I believe that he is one of the most important person to have started the activity of Academy of Biomimetic Dentistry. He visited my department and Professor Fusayama, and he had a wonderful direct lecture from Professor Fusayama, even after his retirement. So this is the specimen of the dental caries. Of course, everyone knows this is caries. However, nobody can tell which part of caries to be removed. Professor Fusayama tried to answer to this question. In 1960s, he started the research of dentin caries. This is the noob hardness number of the tooth in the case of the active region. And this is the same noob hardness number. It is indicated by dotted line in the case of arrested region. In the case of caries region, of course, the softening can be seen like this. Also, in the arrested region, the softening of dentin can be seen here. And point B indicates the bacterial invasion front. And point S, this is the softening front of the dentin. But the hardness is not so easy to indicate the caries region to be removed. Fortunately, we had this kind of caries detecting dye solution that can stain some part of caries dentin region like this. Of course, this part at the bottom of the stained dentin, this dentin is also demineralized and softened, but this part is not stained with this kind of solution. According to this kind of staining, we can remove the stained area. So after that, a lot of studies to analyze the difference between the stained dentin and unstained dentin caries were performed. When we reflect the result of that kind of staining or discoloration of the region, that discoloration front in case of active region is located like this, between the softening front and the bacterial invasion front. That is the same in the case of arrested region. It is located between the softening front and the bacterial front. Then we can remove the region according to the staining or the natural discoloration of the region. As a result, we could remove the bacterial invaded region, even though some part of the caries region is softened. We can preserve this kind of softened dentin because there is no bacteria. And then this is the dentinal tubules, and this is a purple. This side is a pulp wall, and this side is enamel dentin junction. At first, the bacteria came into the dentin, and the bacteria produced the acid. The acid can penetrate much deeper into the dentin, and the deeper dentin is demineralized by the acid. By the demineralization, the calcium ion and the phosphate ions are produced, and they came into the tubules. And after the saturation level, the ions create the mineral crystal precipitation in the tubules. This kind of phenomenon goes down into the deeper dentin, like this. And finally, this part of the dentin is demineralized and softened. And if we think about the sensitivity of the tooth, the movement of the dentinal fluid is very important. By the moving of the dentinal fluid in the tubules causes the stimulation to the nerve fibers in the pulp tissue. So that's why if you cut this part, intact dentin area, very drastic movement of the dentinal fluids occurred. That's why the patient feels the severe sensitivity. That's why you need the shot of Xylocaine. And here, this part is a kind of caries arrested area. And caries, because of caries progress, the so-called transparent dentin is created. In this area, the tubules were occluded by the mineral deposit. That's why in our naked eye observation, this part of dentin can be seen transparent. Then we try to preserve this part of the caries region. This is caries affected region, we call it. And if you apply the dye staining solution, it can stain this part like this. Then we can remove this stained part. We can reflect that result onto this specimen, and this may be the bacterial invasion front. And the acid can penetrate much deeper into the dentin. That's why the softening front is located much deeper of the part of the tooth. And the discoloration on the staining front is located between the bacterial invasion front and the softening front, because the size of the pigment is smaller than the bacteria itself and much bigger than the acid, that is the hydrogen ion. Then you can see the transparent dentin formation at this part. Also at the bottom of the region, you can see the reparative dentin formation. And if you apply the dye solution, this part is stained, and you can remove this part and restore it. This is my clinical case. The patient was a young student, and you can see the hidden caries at this part. Of course, at first, the opening of cavity is done with the high-speed cutting, and you can see the natural discolored dentin caries region like this. And if you apply this kind of solution, a little bit larger area is stained than natural discoloration. And we can move on to the removal, excavation of this stained and discolored dentin. We recommend to use the low-speed steel bar. We don't recommend to use the high-speed cutting to avoid the cutting of the intact dentin. And also during this procedure, we don't apply the water coolant because the rotating speed is not so fast. And it does not create the heating. And also, if we apply the water coolant, we cannot feel the texture of the dentin caries region during the excavation. The texture is also very important information. And this is after the removal of caries, and the cavity looks very deep and seems to be very close to the pulp, but we could complete the removal of the outer caries region without the shot of Xylocaine. And at this part, many of the clinicians still like to apply the lining material like the glass enamel cement to prevent the sensitivity of the tooth. This is extracted molar with big cavity, and using this tooth specimen, we removed the occlusal part of the tooth, make the occlusal area flat, and also the root was also removed. And some part of the pulp chamber is remained here. And in the pulp chamber, we fill lead dye solution. And this specimen was connected with a syringe to be able to apply the pressure from the pulper side. This is the occlusal view of that specimen. We still see the caries region this should be removed in the clinical situation. I removed this lesion and then I apply the pressure from the purple side. Then the red dye solution infiltrated from the pulp tissue, pulp chamber, up to the surface of the dentin through the dentinal tubules. If you see this part, this is the caries. After the caries removal, the surface of the dentin must be caries affected dentin. There is no fluids infiltrated from the pulp chamber because the tubules were occluded by the mineral deposit as well as the formation of the reparative dentin. Also this part, this is the intact dentin area. Intact dentin area, a lot of fluid comes up through the dentinal tubules because the dentinal tubules were open and connected to the pulp chamber. That's why if you scratch this part, if you scratch this intact part, the patient feels the sensitivity or pain. That's why if you cut this part, you need to apply the shot of anesthesia. But in my cavity preparation and caries excavation, I only exposed this kind of caries affected dentin. That's why in my cavity, there is no sensitive part in the cavity. So if you wish to apply the lining material to prevent the stimuli transfer to the pulp tissue, you'd better to apply the material onto this intact dentin surface, not to the caries affected dentin. This is not necessary. And this is the SEM after the phosphoric acid etching. The beautiful etching pattern is observed, but this is the intact dentin surface. And this is the caries affected dentin surface after the phosphoric acid etching. Even after the very strong etching, the tubules were very well occluded by the mineral deposit. This is a very excellent defense system of the tooth against the caries attack. This is another specimen, thin sliced polished specimen. You can see the caries here, and at the bottom of this caries region, you can see the transparent dentin formation. And this specimen was obtained from the elderly patient. That's why because of aging, even the intact dentin area, we could observe some kind of transparent dentin. By aging, the diameter of the tubules becomes smaller and smaller and sometimes occluded by the mineral deposit. Also at the root dentin, because of less number of the dentinal tubules and the much smaller diameter of the tubules, the so-called transparent dentin is seen very frequently. In this case, if we excavate, if we cut only this part, the patient does not feel the sensitivity during the cutting. At this part, we could confirm this kind of crystal precipitation in the tubules, occluding the tubules. And as a result, we can see the transparent dentin. I was so lucky to have assisted the dental clinic of Dr. Takao Fusayama. And he named his treatment technique as the painless restoration technique of caries. He often said that this technique does not cause any pain to our patient. However, my patients sometimes complain about the pain during the excavation of caries. So we try to evaluate the degree of the pain during this kind of painless restoration technique. We utilized the so-called visual analog scale, VAS method, VAS method, and in this method, we prepared the 10 centimeter line and this left end indicate the no pain. Another right end of the line indicate the maximum pain. After the treatment, we requested our patient to mark on this line to show how painful it was. The patient may mark on this, and the line is the 10 centimeter, that is 100 millimeter. So if we measure the length from the 0 point to the marking, we can convert the degree of pain into the numbers from 0 to 100. Then we summarized the result according to the age group of the patient: 20s, 30s, 40s, 50s, 60s, 70s. The higher the age of the patient, the lower sensitivity. I'm sure this kind of phenomenon can be realized in your routine clinical work. With your elderly patient, they seldom complain about the sensitivity without the shot of anesthesia. The younger patient tend to feel more sensitivity. And the total average is about 25. And this is not so much severe pain. When the patient explains the pain narratively, most of the people say, oh, it was slightly painful, but it was a very short period, just the instant. And this is a result of the pain evaluated by the same visual analog scale during the shot of Xylocaine. Of course, the shot is painful. This shot is done by the specialist of dental anesthesia, Dr. Fusayama. It was 50. So I can say that the shot for the caries treatment is 2 times more painful than caries treatment itself. However, sometimes the patient, especially young patient, feel the sensitivity even before the treatment. When you apply the air blasting to the cavity, some of the case shows the sensitivity and pain. In that case, of course, we need to apply the shot. Any kind of excavation technique may cause the sensitivity. But the cases requires the shot of anesthesia is very limited. In my routine clinical work, I seldom use the shot of anesthesia, and the patient acceptance is very well. And many of the patients told me that, oh, I did not know that caries treatment is so easy. The patient must be happy to have this kind of treatment. This is supported by some kind of research results regarding to the permeability of dentin variables. Especially in the case of the intact dentin from young patient, it shows the highest dentin permeability. On the other hand, in the case of the intact dentin from the elderly patient, the dentin permeability is much less like this. And in the case of caries affected dentin from the young patient, still some permeability was detected, but the caries affected dentin from the elderly patient was mostly zero permeability. This is because of this. This is the tooth from young patient, and the intact dentin area very permeable, very sensitive. And this is the caries affected dentin, and it's much less sensitive. And also the elderly patient, even at the intact dentin area the permeability is very low, and the caries affected dentin, it's almost impermeable. So we can go back to this clinical case, and another issue we have to concern about, this is the unsupported enamel. According to the fundamental of cavity preparation established by Dr. G.B. Black, we had to remove this unsupported enamel. But in the case of this kind of adhesive restoration, we can support this unsupported enamel by strong bonding from inside of the cavity. So that's why we can move on to the direct composite restoration. Of course, we don't need to apply the lining. That's why that treatment can be completed very easily in a very short time, because there is not, so the shot of the Xylocaine is not necessary, and we can open the cavity, we remove the caries, and we can move on to the direct restoration. Very simple. So I like to show you two cases of my patient. Both of the patients are almost the same age group. And on the upper case, the lesion is located at proximal area, but the cavity is not open. The lesion is not so big. In this case, at the bottom, the cavity is open because of the fracture of the ridge, peripheral ridge of the tooth. And in this case, the patient come to my clinic to have the treatment on into this cavity. But the upper case, the patient did not feel any sensitivity, any clinical symptoms, but we needed to treat these caries. After the opening, I removed the caries, and also I could remove the outer region from the two cases. I hope you guess which case was more painful. So in this case, the cavity was small and shallow. However, this case caused more pain or sensitivity of the patient because the lesion was too small, and that's why I needed to cut some part of the intact dentin to prepare this cavity. That's why the patient felt very strong sensitivity. On the other hand, the bottom case, the cavity was already open. That's why I did not need to cut the intact dentin. That's why the patient did not feel the sensitivity, pain. So that's why the degree of the pain or sensitivity is not related to the depth and size of the cavity. This is another case of the same patient. When the patient came to my clinic for the first time, he had two cavities like this. And he complained about the sensitivity of this case at the right side, because a lot of intact dentin is exposed after the falling of the restoration. In this case, the restoration is lost a long time ago, and because of that, the dentin, exposed dentin is caries already. So that's why he did not feel any sensitivity in this case. Okay, regarding to the caries treatment, our Association of Conservative Dentistry of Japan provided that caries treatment guideline. And in this guideline, we try to answer to the clinicians. And one of the question is that, is lining necessary for composite resin restoration? And our recommendation is like this: when deep cavity without pulp exposure is filled with bonded composite resin, the postoperative sensitivity is not influenced by presence or absence of lining. That's why lining is not necessary with composite resin restoration, even for deep caries. Okay. This kind of information is published in the Journal of Dentistry in 2012. But still, many of the patients are suffering from the postoperative sensitivity of the tooth. This patient came to my clinic complaining about the postoperative sensitivity, and that became the spontaneous pain. Unfortunately, I needed to remove this restoration. Of course, the restoration looks very nice. However, when I cut this restoration for endo treatment, the two pieces of the restoration jumped off like this. It is because of a very poor bonding procedures, and also a lot of intact dentin was cut already. Unfortunately, even with the novel restorative materials, as far as we cut the intact dentin, the patient had the risk of the post-operative sensitivity. This is the case of my patient after the removal of the dentin caries, and most of the dentin at the coronal part was lost already. However, all the exposed dentin is the caries affected dentin. Unfortunately, the appearance of the caries affected dentin is not so clean, but this is the typical appearance of the caries affected dentin. Then we can move on to the direct composite restoration. This is the X-ray, and you can see that the pulp tissue is very small, even with the adjacent tooth, because the patient age was 60 years old at that time. And also because of the caries, very slow caries progress, a lot of reparative dentin is created in the pulp chamber. That's why the patient did not feel any sensitivity during the treatment. Regarding to the postoperative sensitivity, some of the clinical reports is available. This is one of them, and the single bond, this is the etch and rinse technique using total etching with phosphoric acid. When you apply the incremental filling to the posterior restoration, it showed less sensitivity than that with the bulk filling. It indicates that the prevention of the gap formation is very important. On the other hand, the Clearfield Linabond 2, this is the first self-etching adhesive. And in this case, because of much better bonding performance to dentin, it showed the less sensitivity than with the etch and rinse technique with incremental filling materials. So the bonding performance is very important. Also, the filling technique is also very important. Regarding to this kind of topic, like the performance of adhesive and the manipulation of the new materials, should be discussed in my second lecture after 2 weeks. Also, from the United States, wonderful information is provided. In this clinical research, 28 dentists, clinicians joined, and the total number of patients was 341. And in the case of posterior restoration, the adhesive Clearfield SE bond was selected as the golden standard of the adhesive. And after that, the lining is applied applied in one group, and another group, the lining was not applied. As the lining material, resin modified glass ionomer cement was used. The result was very simple, that the resin modified glass ionomer cement lining did not decrease the post-operative tooth sensitivity. So that's why the lining is not necessary. That is the conclusion of this paper. So I can summarize the difference between the restoration with the excavation of cutting of the intact dentin, especially in the case of non-adhesive restoration. And in this case, we need to cut the intact dentin. Because of the cutting of intact dentin, the inflammation of the pulp tissue is caused, and sometimes some of the cases did not recover after the treatment. On the other hand, in the case of adhesive restoration with minimally invasive approach of caries removal, we are required to remove only this part, outer region. Then, at the same time, we can seal this cavity with a very strong and excellent sealing material. It's a very big difference between two kinds of restorations. I can tell you that the most of reason for post-operative sensitivity is the overcutting of the intact dentin. So in this textbook, he combined the caries removal with caries detecting dye solution, as well as the first adhesive resin material. This material was developed in 1978, and at that time, of course, there was no light cure technology. These are all the chemical cure type of the composite resin and bonding resin materials. So this product consisted of the phosphoric acid etching to both enamel and dentin, and the newly developed the adhesive resin monomer, phenyl P, is incorporated, and they were polymerized by the chemical reaction, autocure type. And very early 1980s, because of the problem in my country to use the amalgam restoration, we needed to develop the composite resin posterior restoration. That's why in my country, we have a very long history of posterior composite restoration using the clear fill and the posterior composite paste. My friend, Dr. Kubo, he is 1 year younger than myself, and he also started the clinical evaluation of the restoration, comparing between the direct composite restoration and the metal inlay restorations. And this is a part of his research on survival rate of the restorations. After 10 years and 20 years, composite resin showed 71% and 62% respectively. And this is almost the same as with the metal inlay restorations. Of course, in the textbook of the dental material, the metal, precious metal, is the most excellent restorative materials. However, as a restoration, the survival rate is almost the same with the composite resin restorations. This is his very old restoration placed with the chemical cure type of adhesive and composite. And you can see that this is the class 1 composite resin restoration placed in 1983. And after 15 years, you can see some porosity at the surface of the restoration because the composite resin was mixed together. And also slight marginal discoloration can be seen. But these change were not so much significant in the clinical situation. And after 20 years, almost the same. And after 25 years, the patient visited another dental clinic and that dentist repolished that surface. Then it became a kind of a new restoration like this. Of course, in 25 years, the surface of the composite is changed. However, the shape of the tooth itself was very much changed because of the function for a long period. So that's why I believe that the mechanical property of the restoration is mostly the same as the tooth itself or less than the tooth itself. So this is my idea about the selection of the restorative material. This is also a very old case of my patient after the removal of the caries region and most of the denting is removed. Of course, I could complete this treatment without the shot of Xylocaine, and the patient did not feel severe sensitivity. I did not have the sheet for the VA visual analog scale, so that's why I showed this handwritten line to my patient, and the patient could mark on the line like this. The degree of the pain is about 30 or less. So then I can move on to the direct composite restoration like this. Because of the poor finishing at the margin of the restoration, there was a gap here, but this can be repaired afterwards. So we can go back to the guideline of the caries treatment. In Japan, lining is not necessary even for deep caries. This is the X-ray of this case. Because this X-ray is a 2D image, that's why we cannot understand the three-dimensional relationship between the restoration and pulp tissue, but we can follow up this case, and so the prognosis was very excellent. Okay. Also, these cases, we could remove the outer caries region. And again, we could remove the outer caries region without the shot of Xylocaine. We always try to follow the instruction of Dr. Fusayama very strictly, but sometimes it's not so easy to remove all the caries region in this kind of cases. Anyhow, we removed the caries region and applied the direct composite restoration. Recently, we evaluated the relationship between the endo treatment and the depth of the caries region after 2 years of the composite resin fillings. In this case, A is the point of the surface of the tooth, and point B is the bottom of the region in the X-ray. And point C is the purple wall. And we classified the clinical cases according to the percentage of the cavity region size. The length of the depth of the cavity was divided by the total thickness of the dentin. Then the result is shown here. In the case when the cavity is less than 80% of the total thickness of dentin, few cases showed, only a few cases showed the endo treatment. And when the cavity size is bigger than 80%, or more, so 10% and 27% of the case needed endo afterwards. We summarize this like this, less than 80% of the lesion depths. Those cases probably would better to remove the caries region and apply the composite resin restoration. The problem seldom occurs. And in the case of the very deep cavity, like 80% of the thickness of the total thickness of dentin, the statistically significant increase of the risk of endo was confirmed. So in this case, we may better to move on to the stepwise excavation technique. And very similar to the stepwise excavation technique, the treatment technique named sealed restoration is recommended by Dr. Mark Fairhurst in the United States. He reported the wonderful clinical results of the sealed restoration even after 10 years. In this technique, the caries region with a lot of bacterial invasion was intentionally left, and the surface is filled with the composite resin with adhesive, and also the sealant is applied onto the surface. If the restoration is kept unbroken, the result is very excellent. So the stepwise excavation of caries is often recommended by many researchers and clinicians. Okay. In this case, we are so recommended to apply some kind of material like the calcium hydroxide or sometimes the glass ionomer cement, and the temporary filling is applied. After some months, we need to reopen this cavity and we remove the region afterwards and apply the final restoration. This is the standard procedure of the stepwise excavation of caries. There is some clinical report showing the advantage of the stepwise excavation technique. In this paper, the stepwise excavation showed better results than non-selective caries removal. This is a single visit caries removal and the restoration. It was shown like this. And also another interesting information is that the pulp exposure rate of the cases. In the case of the stepwise excavation technique, the pulp exposure was 21%. On the other hand, in case of single step, non-stepwise excavation technique, the exposure rate was much higher than that. So to avoid the pulp exposure, this stepwise excavation technique is very effective. According to our clinical guideline for caries treatment, this kind of preservation of pulp tissue is strongly recommended. After the reopening of the cavity, when the region shows some rehardening, we can remove it and apply the final restoration. But many clinicians have a question, is the re-entry really necessary or not? Let's think about that. This clinical report compared the clinical performance between the partial caries removal technique and the selective enamel etching. So in this partial removal of the restoration, the removal of caries was performed, leaving some part of the caries region, and apply the glass enamel cement and amalgam or composite resin. In the stepwise excavation technique, the same removal of caries region was performed. After that, onto the caries region, the dical and the zinc oxide eugenol cement was applied, and after 3 months, we opened and the glass enamel cement and amalgam or composite resin was applied. This study was done in Brazil in 2 big cities. One is Brasilia, and another city was Porto Alegre in the south. The very significant difference was detected at the region. Between 2 cities, the result was very different. In the Porto Alegre, the more failure cases were observed. This is analyzed because of the attitude and the lifestyles of the people in the south of the country. And also another important information is the treatment method between stepwise excavation and the partial removal of caries were very different each other. The stepwise excavation showed more failure cases than partial removal of caries. As a result, the partial caries removal technique showed the 80% of the success rate, survival rate after 5 years, and stepwise technique showed 56% of the success rate. And the advantages of the partial removal of caries region provide us the reduced cost and the procedures, and the duties of the patient was also reduced. And the risk of the temporary fillings fracture is reduced in the case of the single visit restoration, even when we leave the caries region at the bottom of the cavities. In this paper, the same procedure was done, like the first step of the stepwise removal technique of caries. And in one group, restoration was completed at the first step of the selective stepwise removal of caries. In another group, the restoration was completed at the second visit of the excavation. Again, in this research, the pulp exposure is very different each other. In the case of the stepwise technique, at the second procedure, some of the cases showed the pulp exposure. And the cases were followed up for 1 year, and there was no difference of the clinical symptoms between the selective enamel, selective removal of caries and stepwise technique. This is a very old case of my patient, and I removed this old restoration, and the cavity was very big and deep, and I did not like to remove all the stained discolored lesion, and I was not so sure if it is because of the old amalgam restoration or not. I felt somewhat softened at this part, but I filled the composite with the adhesive resin. It was placed in the year 2003, and the second molar has old restoration. It was placed in 1997, and at this moment, this is already 6 years old restoration. And after this, in the year 2011, I needed to apply the repair of this restoration in the year 2011. And 2011. Then This photo is taken last month in my clinic. So as a result, this restoration is the 24 years old restoration. 24 years restoration, and this is the 18 years old restorations. Like this, I hope, I imagine that many of you have this kind of experience, even when you did not completely remove the caries region. In the case of composite resin restoration, the clinical performance is very excellent. But we have to think about the bonding to the caries affected dentin. Regarding to the caries affected dentin, there is a lot of research. And of course, because of the demineralization, the structure is very much different and the water content is higher. And also the mechanical properties is lower. This is a very old paper, but very important to have shown that the caries affected dentin could not be bonded very well because of less percentage of the mineral phase of the dentin. And also, if you apply the phosphoric acid etching to this caries affected dentin, the bonding is very poor because of a very poor penetration of adhesive to the phosphoric acid etched dentin surface. And in this study, the bonding to the outer region was evaluated. The bonding is extremely low because the dentin structure itself, it's very, very weak. It's not a good substrate for the bonding. In this study, we try to improve the bonding to caries affected dentin using this kind of treatment, that is sodium hypochlorite, to sterilize and also to deproteinize the surface of dentin. Of course, if we apply the very low percentage of sodium hypochlorite for very short period, 15 seconds, the bonding was increased. However, if we apply 30 seconds, it decreased. And if we apply the reducing agent named Accel after the sodium hypochlorite treatment, the bonding was recovered. It's a very good information for us. Our recent study also proved that the pretreatment of this kind of sulfonic acid primer, this kind of one-step self-etching adhesive resin was improved for their bonding to the dentin, even with the intact dentin surfaces. In general, this kind of one-step self-etching adhesive, the polymerization is not so easy because the solution itself, it's an acidic condition. That's why sometimes the polymerization is not so easy. That's why we could improve the conversion of those material with this kind of the DC dual cure activator primer. Instead of the sodium hypochlorite solution, we tried to apply the hypochlorous water. And this is very effective to increase the bonding, even without the additional application of the reducing agent. Of course, the smear layer at normal dentin surface and the caries affected dentin is very much different because of much more organic phase in the case of caries affected dentin, the so-called the mud-like smear layer is produced. That's why the removal of the organic phase from the smear layer is very effective to improve the penetration of the material. We call this kind of treatment as smear layer deprotonization. And in this review paper, we conclude that the sodium hypochlorous water can provide us a rapid and broad spectrum antimicrobial activity with less irritating and sensitizing properties. And the subsequent antioxidant reducing agent can enhance the longevity of the composite resin restoration for afterwards. So we can apply this kind of bonding procedures. Of course, the very good sealing at the peripheral part of the cavity is very important. And in that case, even if we leave some caries lesion at the bottom, in the clinical situation, it can work very well. Of course, we'd like to use some kind of procedure to improve the bonding and the situation of this part by applying this kind of solution. And sometimes I gradually start to use silver diamine fluoride. This sulfuride, that is 38% of silver diamine fluoride, is widely used in Japanese dental treatment for many years. And it shows a very excellent performance to prevent caries as well as arresting the active lesions. However, the color of the region becomes very dark, black or brown colors. Now, the very highly advanced aged society, this kind of application of SDF is very strongly recommended. Of course, the color of the region becomes very black, but this is very effective to arrest the region. Interestingly, if you apply the light onto this solution, even without the caries region, the color of the SDF becomes very dark. By the light curing, the color is changed to black. Of course, if we apply this solution onto the demineralized dentin, the discoloration, the blackening is much stronger. And we try to evaluate this SDF solution as the potential of the caries detection. In this paper, we cut the caries cavities in halves, and one half is stained by the conventional dye solution, and another half is applied with the SDF. And afterwards, we observed the blackening of the region, and we compared between the conventional staining and the SDF staining. As a result, the SDF tend to stain much deeper than the staining of the caries detecting dye solution. If you apply the light onto the SDF applied surface, only the surface area is very strongly blackened, but the penetration of the staining is very limited. So that's why we recommend to apply this technique as a two-day method, two-visit method. We apply the SDF onto the region, and at that time, the region is arrested. And interestingly, the hardness of the region is recovered compared to that with the conventional staining solution. So like this, the caries detection with two-visit method provides advantage of arresting caries, chemically and so mechanically. In my clinic, I often apply the SDF in this kind of cases. And after 3 months, some of the demineralized lesion, caries lesion is broken like this. I still followed up for 1 year. And after 1 year, I decided to remove this part and apply the filling like this. So the treatment of caries is now changing from the traditional method. Of course, the minimally invasive philosophy is very important to take care of the caries region. And after this, of course, the bonding procedure is very important, and also the filling technique is very important. So today I did not enough time to talk about the bonding and filling procedures. I'm very happy to be able to provide the information about those issues in my second webinar. And also, I have worked as a dentist for 41 years already. And fortunately, many of my patients are very happy to follow, to accept my dental treatment even after my retirement. So I could have established a very good personal relationship with our many patients. This is one of the happiness as a dental profession. So I thank to all the members of my department, and fortunately, this photo was taken about 7 or 8 years ago, and you can see Dr. Sadal Alireza. He will give a lecture about the restoration and the adhesive materials, because he performed a lot of excellent works in my department, and he still continued in Seattle. And also, this is Dr. Nikaido. He worked for the resin coating technique. In other words, it is said as the immediate dentin sealing, but we have a lot of information for you. And also Dr. Nakajima worked for the bonding, and the bonding to caries affected denting a lot. And Dr. Shimada also worked a lot for the OCT machine development. And finally, OCT was approved by Japanese FDA, and we are very happy to develop the research application of OCT. And Dr. Hosaka is recently appointed as a professor at Tokushima University as a professor, and he will promote a lot of research on adhesive dentistry. So I believe that the activity of my department will be continued or even more, much more active from now. I thank you very much to all, and I thank you very much for your kind attendance. So I hope I can enjoy the discussion with you. Okay, thank you very much.
Thank you so much, Dr. Tagami. Wonderful presentation. Very, very good. Thank you. I'm sure everyone is clapping. Many are commenting right now. Wonderful presentation. Such a treat to have you with us today. We are going to go ahead and launch another poll question for those that are participating in the CE. So Matt will launch our last polling question. And it is up right now.
Okay.
Okay, here it comes.
I forgot.
Wonderful, wonderful, excellent.
Okay.
All right, thanks for everyone putting your questions in. We are actually going to get started in just a moment with our live question and answer. Just before that, we're going to share just a little information about the Academy of Biomimetic Dentistry and tell you a little bit about how to become a member. I'm going to hand it over to Matt Miller.
All right, Dr. Tagami, you and I have spent a good amount of time the past couple of weeks. So I just wanted to personally say thank you so much for that was great. Everyone had such a good time. The comments were flowing in and it was really excellent. So thank you. I just want to go over a few things here as I'm letting somebody in who just showed up right now. I'm going to be going over a few things here just to kind of cover the basis of who we are at the Academy and what we offer. At the root of us, we are an educational and a resource for biomimetic dentists. Our scientific board has a ton of great resources and people on there, and we're constantly striving to improve the education and everything we can bring to you as biomimetic dentists. So without you guys and gals, we couldn't do what we do. What I would like to share right now is a few things about who we are and why you should maybe consider becoming a member. If you've already seen this before, please just bear with me for a minute. I'll be really quick, but it is really important that you guys know that we're constantly striving to bring more and more to you. And we have a two-way communication. So you can communicate to us if you have ideas or ways that we can benefit you all better. Please be sure to let us know. And it's either going to be myself or Carla or Dr. Mark Lazar or one of our board members would be responding to you. Some of the key benefits to becoming a member is you get a webinar recording database. So all of our webinars and anything that we're doing inside of our website, we do have an archive of that, and you get access to all of those things. So that's really great. So for as long as you're a member, you will get access to the webinars that you've purchased, and you also get a listing on our database. So why become a member today? Well, as you can see here, we've got an excellent community of biomimetic dentists, and we're growing. If you guys are not following us on Instagram, please do so. If you're not subscribed to us on YouTube, please do so. It's my commitment as the marketing director to bring more and more and more great content from all of these wonderful biomimetic dentists and great case studies moving forward. As you can see, we've got some of the big names in the space today: Dr. Matt Najad, Dr. Grant Chiz, Dr. David Jerdol, just to name a few of them. And we've got more and more coming. So thank you guys for showing up today. It's really awesome. We also want to let you know about the different levels of membership. So as of right now, we have a basic membership and an advanced membership. The basic membership does get you, I'm going to actually share my screen if you don't mind, see if I can pull that off really quick. So we're already promoting Dr. Junji Tagami's next webinar for April 24th. And I will be, if you guys stick with me for a minute, I will be offering you a $10 off coupon for this one. And that will be good until the end of the day today. And I wanted to kind of jump onto our membership page just to show you a few of the perks and reasons why you might want to consider becoming a member. We're obviously trying to grow so that we can get the word about biomimetics out there even more. So the basic membership as of right now is $295 per year. It gets you a listing on the website. It gets you annual discount for our annual conference, which this year was online. You get access to case studies and a bunch of other great things. The advanced membership basically comes with some marketing materials, which I was just speaking with Dr. Mark Lazar. We're actually going to be building out. So once you learn this great subject of biomimetic dentistry, how do you market it and how do you get it out there to the world? This is the advanced membership. It does have some perks and some items you can use to help market what you're doing so that people understand what it is that you're doing. I would also like to share our accreditation. We worked really hard on our certification program, and we are offering, as you can see here, 3 different levels and a 4th to come. So if you are a current member, please come here to this page and sign our general certification. This is doesn't cost any money. It is free. And you can also become accredited right here. It's through a quiz. Thank you to Dr. Mark Lazar and Dr. Paul O'Malley for working so hard to bring this to everybody. And then we also now offer a fellowship. So I wanted to bring that to everyone's attention as well. It's pretty great. And I think I've covered everything. Webinar record. Oh, one more thing. I want to share the coupon code with you for Dr. Junji Tagami's next webinar. So here it is, ABD10. Take a screenshot or write this down if you're interested in joining us in 2 weeks, which hopefully you are. Up until the end of the day today, we are giving $10 off for the participants of today's webinar. So that would be wonderful to have you join us in 2 weeks from today on April 24th, which is actually the 25th in Japan, which is very interesting. And I believe that's everything. I'm going to put the CE code. So anyone who's getting CE today, you're going to need this code right here. So go ahead and jot this down. This is important for when the survey goes out. You're going to be needing to write that down. That's going to be going out via email. All right. Carla, did I cover everything? Did I miss anything?
You did great. Nice job. So I just also put the code in the chat for the discount for Dr. Tagami's next presentation, as well as the code for those of you that are participating in CE. Please copy that code and use that when you get your email to claim your CE. Next up, we have our live question and answer with Dr. Tagami and the president of the Academy of Biomimetic Dentistry, Dr. Mark Lazar.
Thank you, Carla. Thank you, Dr. Tagami, for an amazing seminar. That was fantastic. There are a lot of questions here. We also want to thank Dental Digest and Melissa Siebert for supplying the CE credits for us. So thank you, Melissa. Much appreciated. We have a great panel of people on this webinar. So after we open up to a number of questions, we will open up so we can have some discussion among ourselves and share. So let's start us off with a few of these questions for Dr. Tagami. Okay, so I have one question from me, and then we're going to go to everyone else. My question is, you have published over 450 articles, more than anyone else I've known in dentistry. So I want to know which one of these articles to you is the most memorable and most important to you, and why?
I always try to perform the most important research topic at each time. So that's why from time to time, I enjoyed very much for each kind of studies. And of course, when we had the new experimental material of the self-etching primer, so we were very much excited to see the result of that bonding. And in my laboratory testing, the specimen showed all the specimens showed the fracture of dentin itself when we apply the conventional testing method. So that's why I thought the research of the dentin bonding was completed already. But after that, we could develop another kind of testing method, like the micro-tensile testing method or micro-shear testing method. Then we could differentiate the performance of the new materials again. And also afterwards, there was the traditional research regarding to the performance of bonding from the viewpoint of the gap formation in the cavity. And when we had the new OCT machine to analyze the gap formation without any invasive approach, we could see a lot of new findings. Even during the right irradiation, the gap is created when we apply the inappropriate filling technique, even with the excellent adhesive materials. So that's why always new problems, new concerns occurs when we have some result of the research. So, but the self-etching primer and the OCT analysis are one of the very exciting information for me in my career.
Thank you, Dr. Tagami. A question someone asked, have you incorporated air abrasion in your caries removal technique?
Yes, that's very important because I know many of the members of this academy use the air abrasion technique for cavity preparation. And unfortunately, in Japan, we don't use air abrasive to remove caries and to prepare the cavities. because of some kind of regulations in my country. But the abrasive technique is very effective to remove the caries lesion without the severe sensitivity to the patient. But I suppose even with abrasive technique, the sensitivity occurs if the intact dentin is removed. So that's why the very careful procedure to confirm the surface of the dentin, dentin floor, uh, because sometimes the abrasive technique tend to over excavation, tend to result in the over excavation because there is no so feeling of the texture of the substrate of the tooth. But the advantage of the abrasive technique is very thin smear layer formation on the surface. That's why the self-etching primer is believed to be very effective onto that surface. And even with that kind of situation, the polymerization and the penetration of the bonding resin and its polymerization is very important to obtain very good bonding. That's why sometimes in the case of the caries affected dentin bonding, the surface should be treated with some kind of the solution to modify the smear layer to remove the proteins from the smear layer. And then after that, for better polymerization, maybe in the future, we the application of the dual cure activator, like the reducing agent application, is becoming a kind of standard of the bonding.
Okay, thank you. Another question is, have you incorporated fiber usage in your biomimetic reconstructions?
Okay, I don't use the fiber materials in my composite resin restorations, but in the case when we need to build up onto the endo-treated molars, sometimes the cavity is very big, and to prevent the gap formation, of course, there are many papers proving the very excellent result of the fiber combined restoration. And but in my case, I prefer to apply the simplified technique. And instead of the fiber application, I apply the flowable composite resin lining onto the bonded surface at first. And like cure, then we can establish the good bonding to the tooth surface, and I can move on to the incremental filling technique afterwards. There are some kind of options to prevent the gap formations.
Perfect. Someone was asking, during caries removal, what speed would you recommend the slow speed to do during excavation?
As a description of the textbook, we say 2,000 per minute, 2,000 to 5,000 rotation per minute. And if we use a big round bar like number 4, number 5, if you gaze that burrs very carefully, sometimes we can see it rotating. So that is the speed. But in the case of elderly patient, the sensitivity never goes. That's why to complete the removal of caries, sometimes I use much faster rotation.
If the person is fully anesthetized, would you increase the speed, or are you going to a lower speed because they're not fully anesthetized?
Yes, according to the patient, and the speed control is very important, but the size of the bar is very important, not to touch to the sensitive part. So that's why at first I start with a big round bar at first, and we roughly remove the outer caries region. And when the patient start to feel some sensitivity, we change the bar to a smaller one, like number 1 or number 2. And then we try to not to touch the sensitive part. The key of the painless restoration technique is cutting only the insensitive part. It's very simple.
Okay. Someone's asking why not use the silver diamine fluoride, to arrest the decay, and then remove only the loose decay with the hand instrument, and then to restore over the arrested decay.
Yeah, some clinicians like to use the hand instrument, and when we apply the silver diamine fluoride, the hand instrument excavation is possible. But for me, I'm not so good at using hand instrument. I'm not trained so much. And for me, using the round bar is much easier and faster. So that's why I always use the round bar.
Okay. Someone's asking, in the study that you had with the VAS of pain during the caries removal without the anesthesia, they're asking how deep were the caries?
The caries, what is that?
The cavity, the depth of the decay, how deep was that during the pain study?
It's so the regions of that research was nearly a half of the total thickness of the dentin. It's of course it includes very deep cavities. And as I mentioned in my talk today, the sensitivity is not correlated with the depth of the cavities. And even when the cavity is very deep, if the caries is the arrested situation, the sensitivity is very lower. And even when the cavity is very shallow and small, if we need to touch the intact part of dentin, the sensitivity is very high. So that's why the sensitivity is not depend on the size and the depth of the cavities.
Wow.
Age is also a very important factor.
Yes. Someone's asking, how many times do we need to apply the caries indicator dye before we could finally start with the restorative part of the procedure?
Sorry, please repeat.
How many times would you apply the caries indicator dye before you decide to restore the tooth?
I teach my student to use the caries detecting dye solution, and the average time of the application was 4 to 5 times. At first, we apply it and remove it, and apply it again and stain, and we remove it. And the average time was 4 to 5 when we had the clinical research. But nowadays, I don't use the caries detecting dye solution. I'm sorry about that, because after a lot of clinical case experience, we can tell the removal of caries is sufficient or not from the information of the color of the region, and also the texture of the region, and also the moistness of the cutting debris from the cavity. When the cutting debris becomes very drier, we can stop the excavation. And when the patient feels the sensitivity, I usually stop the excavation at that point. So, and only when the patient is very young and there is a lot of softened dentin without the natural discoloration. That kind of active caries region tend to be stained very light pink. In that case, we cannot stop the excavation. In that case, I strongly recommend to stop the excavation at that moment and apply the so-called stepwise or the sealed restoration technique after the application of sodium hypochlorite solution and reducing reagent application, and move on to the bonding and filling technique.
Okay. What is the risk in just establishing a peripheral seal zone with a high-speed handpiece and then removing the soft caries with manual excavation and then finally bonding the composite? You may have answered part of this before, but that's the question.
Is the risk of the high-speed cutting?
Using the high speed to create the peripheral seal zone and then removing the soft caries with the manual excavation.
Yes, the risk of that kind of restoration technique is the fracture of enamel or fracture of the restoration, because the basement of the cavity is very soft. But in most cases, nowadays, we can apply a very reliable adhesive material, and good bonding can reinforce the structure of the restored tooth itself. And also, when we feel the restoration is too thin, probably that kind of very thin restoration does not exist in the clinical situation. And in that case, the bottom of the cavity must be very hard substance of the dentin. So that's why, as far as we can obtain the sufficient thickness of the restoration, probably we don't have any risk. However, the restoration should be combined with a very well designed maintenance program. So of course, after the filling and the polishing, it's not the end of the restoration. Including the follow-up, the restoration should be considered as a whole care of the tooth and patient.
Which material would you recommend for a liner, and would immediate dental sealing be just sufficient enough?
As a liner or the resin coating material, we prefer the flowable resin composite. And nowadays, I use the Clearfield Majesty Aesthetic, and because it's we can choose my favorite flowability of the flowable composite, and also after the polymerization, the mechanical property of the recent flowable composite is very strong because of the very excellent catalyst systems and the filler technologies. The filler particle tended to become much smaller than before, and we can continue to use the same flowable composite as an incremental filling technique. And finally, we can complete whole the restoration with the flowable composite only. This kind of flowable composite restoration, it's not from the bulk fill composite, bulk fill flowable. We use the so-called the restorative flowable composite as the whole restoration, including the posterior composite. And this technique, this restoration is now widely accepted in the Japanese clinicians. And of course, many clinicians believe that the flowable composite, its mechanical property is lower than the conventional composite, but the flowability of the paste before polymerization is a different issue of from the mechanical property of the material. You can remember that there were many kind of condensable or packable composite in the past time. Of course, their texture was very hard before the polymerization. But after the polymerization, some of the mechanical property was very poor. Nowadays, because of excellent monomer technology and the catalyst technology and the filler technologies, the mechanical property of the flowable composite is very much reliable. So that's why I'm very comfortable to use them. And the lining with that kind of material is very effective also.
Another question, I know we were talking about not getting certain patients numb when you're doing work. If you were to not anesthetize the patient, how would you make the patient feel comfortable during rubber dam usage?
Of course, I should say rubber dam is mandatory for all kind of restorations, but unfortunately, some of the cases that sometimes the cavity margin is located as much deeper at the subgingival area. In those cases, unfortunately, I cannot apply the rubber dam isolation. So in that case, I apply the matrix to and inserting into the subgingival area and apply the bonding procedure very quickly and apply the flowable composite lining. And I try to elevate the margin of that lining material at the supragingival area. Then after that, we can apply the rubber dam isolations. And but I do not apply the rubber dam isolation for all the clinical cases of mine. And but I always try to apply isolation of the cavity with the cotton roll and some other instruments. And of course, the very careful isolation is needed.
Dr. Tagami, so can clear fill DC activator be used in place of the acel as a reducing agent after the sodium hypochlorite treatment?
Yes, Axel and Clearfield DC activator and the Scotch Bond DC activator, all of them works mostly very similar. And their function is the antioxidant. And they are very excellent reducer and promote the accelerate the polymerization. And the fundamental of the bonding is very good, sufficient penetration into the tooth surface, especially edged surface. And then the penetrated bonding resin should be sufficiently polymerized. For that purpose, the pre-treatment with the activator is very effective.
So why not routinely use the sodium hypochlorite deprotonization and the Excel for every cavity? Would you recommend doing that for every cavity or use it for select procedures?
Yes, at the moment, I recommend to use it in some selected cases. And as I mentioned, sometimes we are not so sure about the removal of caries, especially in the case of the young patient with active lesions. In those cases, I prefer to use that kind of technique.
Okay. Does the silver diamine fluoride affect the adhesive strength?
Yes, it tends to decrease the bonding, but still the bonding is very high and reliable. So I prefer to select the advantage of the application of SDF, but it is limited in the posterior restoration because the bonded surface becomes very black.
So another person is asking, so if you accidentally expose the pulp during your procedures of caries removal, how do you handle that? How do you handle pulp exposure?
Yes, we apply the sodium hypochlorite solution application. And after that, we try to apply the bonding procedures using the Clearfield SE bond. And we, after the bonding application, we write cure, then we cover the surface with flowable composite to provide the perfect sealing at the exposure site. And we complete the composite resin restoration. And this is the final restoration. And of course, we need to follow up the cases. And if the patient has some symptoms, we can move on to the next procedure. Sometimes endo treatment is required. And in that case, the tooth is already restored with adhesive restoration. That's why the endo treatment is very easily applied with that kind of situation. So that's why I don't like to use the temporary restoration onto that surface. And the composite resin restoration is a very excellent final restoration, and it is also very convenient to apply the endo treatment afterwards.
Which generation of bonding agent do you recommend and prefer? And does it matter based on the depth of the restoration?
I'm sorry, I don't understand the classification according to the generation, because it makes us very much confused about the classification of the material. I just classify the reliable one and the unreliable one. And in general, the two-step self-etching adhesive consisted of the self-etching primer, and the light cure bonding is my first choice. And afterwards, of course, in most of the cases, even for very shallow cavity, I prefer to apply the lining with the flowable composite and move on to the incremental filling technique.
Okay. A question about reentry. Wouldn't reentry run a greater risk of aggravating the pulp, because the clinician usually winds up removing even more dentin and going closer to the pulp just to get the temporary filling out? And how long would you wait before reentry?
So for myself, I don't do the stepwise excavation technique because as I mentioned today, the stepwise technique tend to have more pulp exposure at the second procedure.
Right.
So some of the paper proved that the second procedure is not necessary. And but nobody can tell how long that partial removal of caries lesion can work in the mouth. We don't have any information about that, but at the same time, we can provide a very good maintenance program and follow-up program monitoring. And whenever the patient have problem, immediately we can move on to the next procedures. So that's why I don't like to apply the stepwise technique. That's why when I leave the caries region with bacteria invasion in the cavity, I always complete the restoration with adhesive material, and I just follow up. I never reopen that cavity.
I'm going to ask one more question, then we'll open up to everyone to just shout out any questions that haven't been answered and open up to general discussion. The last question is, what are your thoughts about using a glass ionomer in the base of a deeper restoration?
Glass ionomer restoration is very well accepted by the majority of the clinicians. However, I don't use the glass ionomer cement so frequently. I use the glass ionomer cement as a temporary filling of the endo treatment. And also, there is very few cases in my clinic. I use it when the very big cavity, the patient has a big cavity at the second molar and some of the cavity located at the subgingival area. Of course, in that case, um, uh, everybody knows the rubber dam isolation is recommended, but in those cases, we cannot apply the rubber dam, and we try to isolate that area, and I feel the grass animal cement. Probably that kind of case is an indication of the extraction. So in those cases, I feel the grass animal cement.
Perfect. Well, Dr. Tagami, thank you so much. I don't want to take up too much more of your time here. Anyone else? Everyone's been here for a couple hours, and we love it. We could be here for all night. And we're going to open up to questions in case you'd like to stay and invite some more people to to engage. We have a lot of fantastic people on the call. We have a number of our scientific advisors on the call. So obviously, I'd encourage everyone to open up to some more discussion. And we look forward to your next seminar. So anyone who has not yet registered, please register. Use the discount code to get $10 off the next webinar. It's going to be coming up Saturday, April 24th. Again, same time, 5 p.m. Eastern. So please register. We're going to have a lot more of great information, Dr. Tagami. So Dr. Tagami, again, it is such a privilege to have you here with us, and we really appreciate it.
Thank you.
The code on the screen for everyone. Take a screenshot and please use it. And we also like to thank Karari for sponsorship. They have great materials, and we're very, very grateful to them.
Thank you, Dr. Tagami. It was just wonderful. We were so honored to hear you today, and we really learned a lot. Thank you very much.
All right. Thank you, Dr. Tagami. Now would be a great time if anyone wants to and ask a question.
I also just saw a comment that says, can we have Dr. Matt Najad for a webinar? He is coming up in July, so stay tuned for that. We're very excited. Not to give you too much of a
I know. Well, we've got him over here.
I know.
Thank you so much.
We have people from over 25 different countries here on this call. It's amazing, and that's just what I've counted so far. This is wild. So it's amazing to have
From the
people here from
Philippines.
across the world.
So it's an advantage of this kind of webinar. So we can utilize this even after the corona pandemic.
Yes. Yes. If you haven't already, make sure to visit the ABD's website. Dr. Tagami will be bringing us even more on April 24th. We're very excited to have him back. It will be at 5 p.m. Eastern New York time. So mark your calendars and make sure to register so you can get your link to Zoom. And we're very, very excited to have him back again. Thank you so much for carving out the time to be here for today's presentation. We are so lucky to have Dr. Tagami all the way from Tokyo talking to us. So thank you so much, even during the masters. So awesome, so awesome.
Okay, thank you. Thank you. Now, so everyone, I'm now on sale. Thank you.
All right, that's perfect. Thank you guys very
Thank you.
much for attending. If anybody has anything else, drop a line in the chat or unmute. And if you have to get running, please have a great, safe rest of your weekend.
Yeah.
You too. Thank you so much.
Thank you.
Great.
Lots
Thank
of
you
thank
so
yous
much.
to Tagami. Everyone's saying thank you.
What percentage sodium hypochlorite are you using?
Percentage, yes. It's a very low percentage, 50 ppm, but it's almost the same as the percentage of the sodium hypochlorite used for the endo treatment.
I wanted to ask, could you repeat how you use the sodium hypochlorite in your cavity and the process and indications for that?
So sodium hypochlorite solution, yes, of course. Nowadays, I tend to remove the caries so much, and maybe in my recent cases, I left a lot of caries dentin. So that's why in that cases, of course, there is no evidence, but I prefer to apply the sodium hypochlorite solution as a cavity cleaner, because in my country, we don't have the very good cavity cleaner. We cannot use the chlorhexidine solution. So that's why the sodium hypochlorite solution or hypochlorous water may be a very good option as a cavity cleaner. As far as we use that kind of oxidant solution, we need to apply some reducing agent.
Anybody else have anything?
One quick question, Dr. Tagami, can you just comment on the use of bulk fill composite resin, but using it in a technique of incremental placement? Is there any benefit to that?
Of course, the bulk fill composite is very well designed, but still its performance is not perfect. Even with the bulk fill composite, there is some discrepancy between the real performance and the comment by the manufacturers. So that's why we don't totally trust their performance. That's why I prefer to apply the incremental filling technique. But of course, we have to be very careful to use them according to its mechanical properties after the polymerization. And for most of the clinicians, the changing the material and the product is not so easy. So that's why I am very conservative to change my material in my clinical work. And it's also the same for the anterior restoration. The shade of each product is very variable. So that's why I'm very comfortable to use the same material, because I know that performance, especially regarding to the color matching and the polishing properties or so on.
I would like to ask Dr. Tagami that how does he manage post-operative sensitivity in the patients that come around to his office? Like, do you go with the medical route, or is it directly that you go for endo after that?
Maybe the question is how I can manage the post-operative sensitivity, but in my case, mostly I don't use the shot of Xylocaine, and during that procedure, the patient doesn't have sensitivity. So that's why there is no reason of the post-operative sensitivity. So the management of my post-operative sensitivity is to apply the minimally invasive restoration procedure application. And so if the patient come to my clinic complaining about the post-operative sensitivity, I try to wait for some weeks and to watch the change of the clinical symptoms. And if the situation is not changed well, I remove the restoration and reapply the restoration with my procedures. Then watch them. If not, unfortunately, we have to do endo.
Hello, Dr. Tagami. It was a wonderful presentation. I just want to know, heated composites are good for deep caries. Do you recommend heated composite to be as a restoration?
Yes, of course. I don't know why the people tend to apply the very hard restorative material to a big cavity and deep cavity. The deeper the cavity, I'd better. So the harder material may have some problems because the remaining thickness of the tooth substance is smaller. So that's why we should reinforce the remaining tooth substance with strong bonding with the direct composite restorations. And the mechanical property of the composite is not so different from the dentin characteristics. if you apply the very hard material like ceramic and zirconia, sometimes they are too hard and they broke the natural tooth and so antagonist tooth. So that's why I prefer to use the composite as a very biocompatible mechanical property.
Doctor, as a clinician, are you moreover a total edge person or a selective edge person?
Sorry, I could not hear well.
I wanted to ask if are you like as a clinician, are you more into total etching technique or selective etch technique? Which one do you prefer more?
Which technique?
Total etch or selective etch?
Ah, yes, the selective enamel etching is recommended when you use the so-called universal bonding, that is one-step self-etching adhesives, because the etching performance of the one-step self-etching is not strong enough for enamel bonding. That's why the enamel margin should be etched by the phosphoric acid before you use the one-step self-etching adhesives. But in the case of the two-step self-etching adhesive like SE bond, the bonding to the cut enamel surface is good enough. But sometimes the marginal discoloration occurs at the peripheral part outside of the enamel margin. We can see the slight discoloration. To avoid that kind of phenomenon, sometimes the enamel margin is etched with phosphoric acid even when we use the two-step self-etching material. But in our recent study, the DEJ is very heavily damaged by the phosphoric acid. And sometimes the DEJ is broken and separated, and the gap is observed in the cavity after the polymerization of the composite, especially when we use the phosphoric acid etching to DEJ. So that's why the application of phosphoric acid to DEJ is strictly avoided. Probably that is a cause of the chewing, so post-operative sensitivity during the chewing stress in the case of posterior restoration. That phenomenon could not be clarified without the OCT machine. So OCT analysis provide us a lot of so very exciting information. So now my interest in research is the DEJ performance after the restoration.
Dr. Tagami, after applying sodium hypochlorite or hypochlorous acid, do you rinse with water before bonding or you directly bond it?
Yes, of course. Yes, of course. We try to remove all that solution because the residual oxidant is very harmful for the polymerization of the bonding resin. So that's why the sufficient water rinsing is recommended. But still, some residual oxidant exists at the surface. That's why we need to apply the DC activator.
Dr. Tagami, after you apply your thin layer of flowable resin on your hybrid layer, do you feel we have to wait, give it time?
No, I cannot wait in the clinic.
Okay. So we can go ahead and immediately start with the incremental technique.
Yes, at first we apply the light irradiation onto the bonding resin. And at that time, I try to apply 2 times or 3 times of the irradiation to make sure the polymerization of the bonding. Then we apply the flowable composite and apply the light curing again. Then at that time, through the thin layer of the flowable composite, the light is applied to the bonding layer again. That kind of indirect irradiation also very effective to increase the bonding to the tooth surface. Then we can create the very reliable bonding And so that's why it's better to consider that, to think that including the lining, flowable lining, it should be involved as a bonding procedure. Then you can move on to your favorite filling technique immediately after that.
Thank you. And your filling technique, would you do horizontal increments, or can you go up the buccal and the lingual walls, let's say in a class 2?
In the class 2, at first, I try to seal the gingival margin at first. And I apply 2 times or 3 times of the light irradiation to make sure the polymerization. Then after that, it's up to the size of the cavity, but usually I feel the half depth of the half part of the proximal cavity. And then usually in case of the premolar, I apply 2 times or 3 times. Maybe at first the sealing at the gingival margin and fill up about half, and about half I fill up again. And as a final filling, maybe I can say it's the fourth increment with the flowable composite. Of course, flowable composites tend to show more shrinkage volume. However, the flow of the material itself is very beneficial to prevent the gap formation, because during the polymerization, the shrinkage is reduced. The shrinkage stress is reduced because of the deforming of the flowable composite itself during the polymerization. When we use a very hard composite resin material, sometimes the shrinkage volume is small, but the flow during the polymerization is also very small. As a result, the gap is very easily created. The shrinkage stress is compensated with the flow of the material itself.
Mm-hmm. Very interesting. And your gingival layers, they're always flowable?
Yes.
Okay, yeah. Thank you. Thank you. That's very, very good information. Thank you.
All right, everybody. I think I'm gonna wrap it up here. I have one more question, and then we're gonna shut her down.
Yeah.
I can ask this question. He wanted to know about the repair strength, the repair protocol for repairing composites.
Repair protocol, yeah. So I intended to talk about the repair protocol in the next webinar, but this is a very good opportunity to talk. And so in the case of repair, of course, we need to bond the composite to enamel, dentin, and all the restoration surfaces. And in that case, of course, the cut composite resin material is also covered by the composite smear layers. To clean that surface, the phosphoric acid treatment is very effective. So that's why I try to apply the phosphoric acid to the material surface and the enamel surface together. Then rinse and dry, and then we apply the self-etching primer onto the whole surface. Then I mix the silane coupling agent with the remained self-etching primer together, mixed together, and apply it onto the whole surface. Then the silane coupling treatment is done onto the old composite resin material or ceramic material. And the application of that silane coupling agent solution onto the dentin surface does not influence the bonding to the dentin and the enamel. So that's why at first we apply the self-etching primer itself onto enamel and dentin. Then we mix the silent coupling agent and apply it onto the whole surface, because we cannot control the application surface because that solution is very, very thin and flowable. Then we apply the bonding resin and light cure and fill the composite. And if we think about the bond strength, the bonding to enamel and dentin is very reliable. However, the bonding to the old composite is very influenced by the filler type of the material. But we cannot tell which kind of material was used as the old restoration. That's why, as a common procedures, we do apply that kind of procedures using the silent coupling agent. And the bonding to the ceramic and the metal is not so much reliable in the clinical situation, even though we have the primer for each material. So that's why I try to apply the mechanical interlocking or the retentive form in the material itself. I make a hole in the material for the better retention, and we apply that procedure.
Doctor, certain clinicians, while doing the incremental technique, they use modeling resin. What is your take on this?
What I use the flowable
No,
resin material.
Some clinicians, they use modeling resin while they place the increments just to shape the resin a bit while they do the restoration. So what's your take on modeling resin? Should we be using it or should we avoid using it?
Yeah. After the lining onto the bonded material, bonding resin material, we can choose any kind of material, especially in the case of anterior and posterior restoration. The surface, the final layer can be finished with any kind of material as you like. Sometimes I use the paste type of the composite to apply the anatomical form at the surface. And sometimes I use the material for the better polishing performance to obtain good aesthetic results. You can choose any kind of material.
Okay. Can I wrap it up for everybody? We still have 100 people on here. I don't want to say goodbye, but I'm going to say goodbye. I've got the magic button and I'm going to end it. So thank you so much, everybody, for joining us. Dr.
Thank
Tagami,
you.
thank you so much.
It's wonderful.
We'll see everybody in 2 weeks. Please join us.
Thank you.
Thank you.
See you again.
Good night.
Dr. Tagami. Good night, everyone.
Thank you very much.
Good night. Thank you. Bye-bye.
Thank you.